And I have a reference for you in Chapter 15 on this. Table 15-6 specifically instructs us to, and this is a quote, identify the muscles performing the motion, comma, and the spinal nerves involved, and then grade the severity of motor deficit of individual muscles. And that's an unquote. So Chapter 15 is all about individual muscles. Chapter 16 and Chapter 17 is about both muscles and motions. And in Chapter 15, I've reprinted for those of you that have the PowerPoint or those of you that are using your handouts, Table 15.2 tells us which muscles we are to focus our manual muscle testing on. For the nerve roots of L4, we're going to be involved with the quadriceps. For the L5 nerve root, we're going to be testing the extensor hallucis longus. For the S1 nerve root, we're going to be doing the ankle plantar flexors. For the C5 nerve root, we're going to be doing the deltoid muscle. For C6, we're going to be doing the biceps muscle. For C7, we're going to be doing the flexor carpi ulnaris and flexor carpi radialis muscles. And these are specific muscles that we're required to be able to isolate and to be able to test accurately for determining permanent impairment in Chapter 15. In Chapter 16, references specific muscles in Table 16.12a, and it requires that we test specific motions in Table 16-35. So let's review these tables here briefly. In your handout materials, and those of you that are watching the PowerPoint presentation, I've reprinted here for you Table 16-12a. This is where we are required to perform testing of specific muscles in the determination of permanent impairment due to peripheral nerve injury. So, for example, we're required to test specific muscles, for example, the coracobrachialis. We're required to be able to test the biceps brachii, and we're required to be able to test the brachialis muscle in cases of permanent impairment due to injury to the musculocutaneous nerve. We're required to be able to test the teres minor muscle. We're required to be able to test the deltoid muscle in cases of injury to the axillary nerve. For injury to the radial nerve, we would be required to perform manual muscle testing on the triceps brachii, on the brachioradialis, and on the extensor carpi radialis longus. For injury to the median nerve, we would be required to test the flexor digitorum profundus muscle to the index and the middle fingers. We would be required to test the abductor pollicis brevis muscle and the flexor pollicis brevis muscle. And by the way, this is quite a bit of detail and quite a bit of upper extremity neurology, and a discussion of all of that is beyond the scope of this program. However, in another program regarding upper extremity impairments due to entrapment neuropathies, I go into extensive, much more lengthy discussion about all the motor and sensory impairments associated with upper extremity peripheral nerve entrapments and other upper extremity peripheral nerve injuries. And I simplify the procedure for determining the motor impairments so that it's not necessary to be able to test every single muscle innervated by each of the upper extremity peripheral nerves. But here you just get an idea what the AMA guides considers to be the depth of the knowledge that we are required to be able to access should it become necessary with each of our individual examinees. Further in Chapter 16, in Table 1635, Chapter 16 moves from testing specific muscles into testing specific motions. And in Table 1635, it describes the motions to be tested at the shoulder and motions to be tested at the elbow. And for example, at the shoulder, we're required to test shoulder flexion, shoulder extension, shoulder abduction, shoulder adduction, and shoulder internal and external rotation. And these are compound movements performed by many muscles. And so, for example, what are some of the muscles that contribute to elbow flexion? Elbow flexion. What are some of the muscles that contribute to elbow flexion? I'll ask you. Well, certainly you have the biceps muscles, right? That's an obvious answer. You also have the brachialis muscle. You also have the brachioradialis muscle, since it crosses the elbow joint and attaches on the humerus. That contributes to elbow flexion. You also have the flexor muscles of the forearm that originate on the medial epicondyle of the humerus. Those are also weak elbow flexors. What about the the forearm extensor muscles that attach on the lateral epicondyle? Those contribute to elbow flexion depending upon what's taking place at the wrist. And so I mention this just simply to indicate that these are compound motions that involve many muscles. And so the AMA guides in chapters 16 and 17 require us to be able to do both, to be able to isolate muscles and also to be able to isolate motions. Chapter 17 follows a similar pattern. We test specific motions and we grade our findings according to the descriptions in Table 17.8. And we describe and grade and test specific muscles in Table 1737. And for those of you that have your handout materials, I've reprinted for you here Table 17.8. Herein we are testing specific motions, and we're going to get into these here shortly, with our focus mostly going to be on those motions that carry with them the greatest impairments. And that would be the motions of hip abduction, hip extension, knee extension, and ankle plantar flexion. Specific muscles that we're required to be able to test are described in Figure 17-9. And it includes those muscles innervated by the femoral nerve, including the quadriceps muscles, muscles innervated by the obturator nerve, such as the hip adductor muscles, and many muscles innervated by the sciatic nerve, whether it be the tibial or the peroneal divisions of the sciatic nerve, including the extensor hallucis longus, the extensor digitorum longus, and the gastrocnemius, and the flexor digitorum longus muscles. So, interesting patterns in the AMA guides. They require us to be able to isolate specific muscles and also to be able to isolate specific motions depending upon what is the cause of the motor weakness. In the case of neurologic injury, we're required to isolate out specific muscles. In the case of non-neurologic injury, such as a fracture, a contusion, then we determine muscle impairment by testing specific motions. Okay, so further general principles, and this is right from the AMA guides. With the AMA guides, we first have the subject move through the full test range of motion. That involves a concentric muscle action. Once the examinee demonstrates the capacity to move through the full test range of motion, then the subject assumes the test position and holds at the test position while the muscle is in its shortened position, and this involves an isometric contraction. Now the resistance is applied as an isometric hold at the end of the test range to determine the appropriate muscle strength grade, and the resistance is always applied at right angles to the long axis of the segment being tested, and always applied pressure directly opposite the line of pull of the muscle or the muscle segment being tested, and this helps to elicit the desired muscle action.